Thank you, Dr. Bhandari, and I think let's all give him a round of applause for the hard work that has gone into doing this. I was wondering whether we should do this more as an interactive panel discussion. Does this represent the landscape of robotics in India, that most surgery is done by urologists and then GYN and then general surgeon, or is this atypical? Is this true? Which specialty does the most number of cases?
Across the India, it's the urology.
Urology still does.
Then number 2 is surgical oncology.
Number 2. Yeah. So in the U.S., that has changed. The number 1 specialty by far is general surgery. The commonest operations are hernias and gallbladders. GYN is second with hysterectomies and then urology. And this is something that I think Dr. Bhandari and I both expected, and I'm just surprised that in the US it's taken 20 years before general surgeons have stepped up to the plate. So as you look into the future, I would not exclude the fact that the spectrum would change in this country. Why did urology be the first specialty? And was it because Intuitive Surgical designed robots for urology? What do you think? Or I'll ask the panel.
Yeah, so my perspective on this is it was designed to make pelvic surgery easier, and pelvic surgery for urologists is essentially prostate, which was at that point in time one of the most difficult surgeries to do. So I guess that really made a difference because the other procedures were being done laparoscopically by urologists.
So I think both of you are wrong.
Also, one of the issue is
another perspective.
Yes.
The MIS technical skill in this country at least is the highest in the hand of general surgeons. And for them to go to an alternate pathway of MIS, which is much more expensive, there's more resistance.
Yes, but I'm not talking about in this country. I'm talking about why in general across the world, or
so
in the
across
US.
the world too, the general surgeons and the GI surgeons had a higher level of MIS skill, and the urologist wanted to do it the MIS way, but maybe the robot came as a bigger help to him than to the general surgeon.
So I think you're hitting to the truth here. And Deepak, go back in time, in 1997, and you have a company that is privately funded, that is trying to have a niche in the marketplace. And the companies are about dollars and cents, and if you don't make money, your company doesn't exist. So they were thinking of a field in medicine or in surgery that would generate revenue for them. And if you were thinking along that lines, I'll now turn to the Indian scenario. Which is the field of surgery that generates the most number of dollars?
In India?
In India.
In urology, I would think stone surgery.
No, I'm just talking about patients paying money. Which field is it?
Oncology.
Oncology. In the US, it might be oncology, but more clearly quantifiable was cardiac surgery. So this robot was designed, the business plan behind the robot was to do minimally invasive cardiac surgery. That was plan number 1. plan number 2, and plan number 3. The first 18 robots went to cardiac surgery departments across the world. And this made sense because the company wasn't giving the robots away. It was selling untested technology at a cost of 7 to 10 crores. And because cardiac surgery generated enormous number of dollars, it had dollars for research and investment. It was philanthropically easy to make a pitch to a patient saying, you have a big sternotomy and your recuperation is long. If we can do the operation minimally invasive with the robot, if we can do it minimally invasive, your recuperation will be better. And we want to get this $1 million robot to do this because we don't have laparoscopic skills, so we're not doing laparoscopic cabbages. We think we can do it with the robot. And so they would get the robot, and the robot would sit idle because the cardiac surgeons were not prepared or were scared of making the commitment to developing a whole new thing. Now, companies have intelligent people, much like politicians do, and sometimes doctors do too. And so the cardiac surgery model was not working. What would plan B be? Close the robotic company or do something else?
Find new indications.
Find new indications.
And induce into the surgeon's mind this is made for this.
Yeah. And their second strategy was to go with the general surgeons. And again, they went with general surgeons because of two things. One is the volume of general surgical procedures exceeded the volume of even cardiac surgical procedures. Now, the profit margin for a cardiac procedure was greater than for a general surgical procedure, so there were less disposable resources in departments of general surgery, but the overall number of cases that Intuitive would do, and if you are charging per instrument per case, it's a lot better to do 50,000 cases, at $1,000 instrument fee than 1,000 cases at $1,000 or $2,000. So they felt the same way, that the skills of the general surgeons in minimally invasive surgery was unparalleled. I mean, if Dr. Palanivelu had been here, he was known for doing a Whipple procedure in 45 minutes laparoscopically. Those skills simply the other specialties did not have. Urology didn't have it for sure, nor did cardiac surgery or anyone else. So this seemed like a very good situation. You've got extremely skilled general surgeons and a high volume of cases, high profile surgeons. So this should be a general surgical robot. And why did that not happen? Or did that happen? It hasn't happened in India so far. It's happening in the US, but it's 2019 and the robot has been in existence since 1997.
Because the cost margin was, for anything to be successful, the economical viability and the quality it added and the cost there is a mismatch in general surgery, unlike other major procedures like oncology in Europe.
So there was a mismatch in general surgery because of the cost, and this will, I'll go astray because there's another trend of thought that I want to do. What is your opinion?
I think the scenario over 10 or 12 years has changed because when the robot came in, it was exposed to the surgeons who already had the laparoscopic skills. So there must be, or there was probably some resistance to add extra cost to what I could probably do it laparoscopically.
Yes.
So the newer surgeons that are coming are not that proficient. They're exposed to laparoscopy and robotic in their training period. and probably picking up the technology because they realize it's more enabling and much easier to do.
Yeah.
So they are not doing that hard work of 12 years or 15 years of learning experience that we did.
Yeah.
So I think that's probably changing the scenario now.
I think, as far as general surgery is concerned, I would probably classify into two groups. One are very straightforward procedures which can be done with lab. There is no requirement for robot. And say, if you take like other group of procedures like Whipples and all, probably only volumes are very less. So which probably didn't cater to the use of robot. So that could be the reason.
So these are all the truths. But I'm now sitting as the CEO of Intuitive. My first model has failed, and my second model is absolutely destined to fail because I'm pitching it to laparoscopic surgeons, and laparoscopic surgeons say, well, we can already do it at 1/10 of the cost, so why do we need to get this machine? So no general surgeon stepped up to the front. Well, then they ended up with the urologist. And that urologist was me, with Ashutosh Tiwari, who was a resident, and Dr. Bandari was not quite there. I mean, I'm sure he, I would brainstorm with him even when he was in India. It was a single urologist who expressed interest in them. It wasn't that there were 50 urologists going to Intuitive and saying that we all want to do radical prostatectomies and can we get a robot. Wasn't. There was just one person. So as far as Intuitive is concerned, it was Menon or bust. And the odds overwhelmingly looked like the equation was going to be balanced into the bust part of it. I was a 52-year-old surgical oncologist, maybe. I was a very good open surgeon. I was a terrible laparoscopic surgeon. I just, I had no laparoscopic skills. So I did not meet their profile. I was not a cardiac surgeon, who was their first thing, and I was not a laparoscopic surgeon. Did we succeed? And how was I able to do it? I'll go back a little bit. And the cost factor was there for me also, but I had some edge to my, something in my pocket, and that was the Varikudi Foundation and Mr. Varikudi. Mr. Varikudi was committed to building a minimally invasive surgical program, and then he was committed on having me do this. And all I had to tell him is that I'm not a laparoscopic surgeon, so if you want a minimally invasive surgical program, you have to encourage me to develop robotics. It worked for me because I did not have laparoscopic skills. So all I was trying to do was to do a minimally invasive surgical program the way, prostatectomy, the way I had been taught to do an open prostatectomy. So I did not use any of the skills that I would have used had I been, say, like Indrabir Gill, who was a very, very gifted surgeon, or Ashok Hemal. I wanted to do an open operation. All I wanted to do different was, instead of making an incision, you put in the ports. It also gave me the advantage that if I failed, I could convert to an open operation, since I was very skilled at doing that. Most laparoscopic surgeons in the United States, they bypassed open surgical skills and went straight from residency to endourology and laparoscopic surgery. So in our scenario, it was different. But you raised a very good point about the cost. And you can spend $1.5 million to get the robot, but you have to come up with the costs for the running expenses. So where do you do that? And how do I come up with the cost? And it became clear to me that, that I couldn't do it. The ideal thing would have been if Intuitive had stepped up to the plate and said, listen, you're doing our R&D for us, so for the first 100 patients, we will underwrite the costs. They were not about to do that. They were 2 weeks from going bankrupt. They had no money. The shares were selling at $3 a share. And if 2 of their private investors had pulled out, that would have been the end of robotics, and it would never have come back because, you know, it would have been an utter failure. So they were not in a position to fund this. It would be a hard sell, even if they had the money, to get them to fund this, to show that this is a good return on their investments. But I came up with this brilliant brainwave that we're talking about costs. Who is bearing the cost? It's not the patient. In the US, if you have a patient who has an insurance, and that's 99% of the patients who would contemplate robotic surgery, or more than that, you are bound legally to accept what insurance gives you. And insurance would only pay you for a procedure that they had approved. So we were stuck that we could bill for radical prostatectomy, and insurances would cover radical prostatectomy, but the additional costs of the robot were unfunded, and we had to self-fund that program. To some degree, it was funded by the Vaticuti Foundation, but to a large degree, it was the hospital making a financial guess that the increased patient volume would make up for the loss per case. I thought those numbers were off, but it was not my business to tell them this and prove the point. And indeed, that's what happened. The patient volumes did come, but more than that, the payer mix changed. Before 2013, when insurance flattened, you could have a patient whose insurance paid you $20,000, or what is that, 15 lakhs for a radical prostatectomy, or $2,000 or 1.5 lakhs. And it's the same operation, but depending on the insurance they had, you got paid differentially. And many of the people who came had insurances that did pay $20,000, which allowed them to go to the Mayo Clinic or Memorial Sloan Kettering or Johns Hopkins or Henry Ford Hospital. But since Henry Ford Hospital was the only thing offering robotics, they felt we had an edge. Well, if you fast forward 4 or 5 years, robotics caught on for radical prostatectomy. When I first started, I was not allowed to have the residents train in robotic surgery. The American Board of Urology would not recognize any of the cases because this was considered experimental and of no value for residency education. People who did the cases did this with that understanding. I was not allowed to force someone to train in robotics. They had to come out of their own free will. And what now happens is, if you do not have a robotic prostatectomy program in your department, you are not allowed to train residents. It's just flipped the other way around. So, we were talking about randomized controlled trials and their value. and from the audience, this is all historical fact, and I may have taken away some of the heartache and the struggles that were involved in it, but this has happened, and it's very easily verifiable, you know, if you just use Google or any other engine. Now, I'd like to ask the panelists, but I'd also like to hear from you as to your impressions as why did this happen? Why did robotics take off in urology? How did we overcome the cost barrier? And why did it become a standard of care? Open radical prostatectomy had been done for 50 years. All the top urology surgeons opposed robotics. They were open surgeons, and they felt just the same as the laparoscopic general surgeons did. We know how to do this operation. Why do we need to learn something new and add cost to the patients when there's no way that we can do this as well with the robot as we can do without the robot? And some of you may have been part of these discussions. So what happened? Why did it change?
So firstly, prostate cancer in the US was one of the most common cancers requiring treatment. Secondly, I think at that point in time, the radical prostatectomy was under the domain of a handful of, or a limited number of very experienced surgeons with a large number of cases. And it was considered a difficult operation, as you yourself, you perhaps trained in one of the best centers for that, but that kind of training was not available to a large number of urologists, and they couldn't perform the procedure to that level of expertise because it was complicated, and that's why.
So what do you think the average number of radical prostatectomies done per surgeon in the United States was in the 90s?
I wouldn't be able to answer that.
So yeah, I don't think you would, but if there were 100,000 radical prostatectomies done and there were 100 surgeons doing them, you would think that the average would be 1,000 cases per surgeon.
Yeah.
There were about 80,000 radical prostatectomies being done, but there were 10,000 urologists doing them. So some urologists were high profile, but the median number of cases per urologist was 4. So 4 per year. So an open radical prostatectomy was done across the country. It was done by every group. It was done in every hospital. And I'm not sure whether it's median or average, but 4 was the number that came into mind. At Henry Ford Hospital, we did 140 open radical prostatectomies a year. I did 60 of them. Sorry, let's add another 40 because I did 60 of them, 40 at an outside hospital, not at Henry Ford. The vice chairman of the department did 40, and 60 cases were divided among 15 other urologists. So our average clearly was the national average 4. So, and it is a tough operation, and I don't think you can do a great job doing 4. So that doesn't make sense. Maybe the reason was that I was so sophisticated that I did a randomized controlled trial to show that robotics was better than open. Do you think that was possible? Do you think that was the scenario?
No, I don't think so, because the learning, at that phase you would have been going through the learning curve. So initially you have to take a step backward and then move ahead.
Yeah. So I did not do a randomized controlled trial. And now after this preamble, I'm coming to why I didn't do a randomized control trial. And there could be many reasons for it. One is, you know, I wanted to sell my technique and my thoughts, and if I did a randomized trial, maybe I will be disproved, that I didn't have the ability to do the randomized trial, nor did I have the intellectual desire. And some of it is partly true. I thought of doing a randomized control trial, but I didn't want to jump into it right away. A randomized control trial of high quality would have cost $30 million, which I didn't have. I was highly unlikely to get funding from the government to do this, since essentially robotics was considered experimental, and you don't do a randomized control trial until you've shown it's one standard technology versus the other. And in order to have this accepted as standard, I would need 15-year follow-ups for oncologic control for prostate cancer. So there were blocks in doing this. I could have done a single institution randomized control trial, and I wanted to do it. I felt that at 100 cases, I was comfortable with the robot. I was so comfortable that, if you notice, I'm holding my mic in my right hand. I do nothing with my left hand, but I could do a robotic prostatectomy with my left hand because the instruments took away the need for my having a right dominance. But essentially, everything that I had done up to that point, and everything that I do at this point, is talking to the patients and listening to the patients and seeing what their needs are. I could backtrack and tell you how that was, listening to patients was the fundamental reason behind developing robotics, but I'll just tell you about the randomized control trials. What I did is I did what is now called a focus group or a pilot study or a sampling. 30 patients in consecutive that I saw, I gave them a simple questionnaire that I had made up. And the questionnaire started with a preamble that said, I am a very experienced open surgeon. I have done 1,000 open radical prostatectomies. I have done 30 robotic prostatectomies, and I feel advantage to the robotic procedure compared to the open procedure in my hands. I'm not saying that it will be true for anyone else. I'm not saying it will be false for anyone else, but in my hands, I see an advantage. But before I can be true to you, before I can talk to you with a straight face and tell you that robotics is better or not, I have to do something called a randomized control trial. In this scenario, you will come to me for your radical prostatectomy, and it's just me. And I will flip a coin or put your number into a computer, and the computer will say, you have open surgery or you have robotic surgery. And this is the randomization protocol. And then depending on what the computer says, that will be the operation that you have. And that was the preamble. And then I asked them a few questions. Did you understand what I said? And all 30 said yes. And I said, did you understand that when we talk about robotic surgery, we don't have clear evidence that this is a better approach? And all of them said yes. Do you understand that in order to get a clear evidence, we have to do a randomized controlled trial. Yes. We are not offering a randomized controlled trial, but were we to offer a randomized controlled trial, would you be willing to participate in the trial? All 30 patients said no. So this is why we didn't have a randomized controlled trial. Surgical randomized controlled trials are difficult to do. Surgical randomized controlled trials are even more difficult to do. They have been done, but the effort was much more than a single surgeon working in a Detroit hospital could. For the purposes of this, what Dr. Bhandari and I talked about is, given that this is a general audience, I wanted to look and see how many randomized trials have been done comparing open surgery and minimally invasive surgery. And Saurabh Arora, who has worked with Gagan Gautam and Rajesh Agarwal, and who has caused me to lose all my hair, did an analysis, and the top trials comparing minimally invasive surgery and regular surgery was looking at disc surgery, microdiscectomy. Then we looked at cholecystectomies, we looked at hysterectomies, we looked at colectomies, we looked at hernias, we looked at radical prostatectomies. And Saurabh did a Cochrane meta-analysis that looked at the meta-analysis of all the disciplines. There were about 43,000 papers that had randomized controlled trials in there. And then you go through the methods, and 90% of the papers were eliminated from the analysis because the methodology was flawed. 10% of the papers were included in the analysis, but the outcomes were very specific. Dr. Kishore and I were talking about a randomized controlled trial that we did do, which was comparing the anterior and the posterior approaches of radical prostatectomy. When you apply for a randomized controlled trial, you have to tell them, the IRB, what your endpoint is. And the reason we were doing this trial is because it appeared that the posterior approach was associated with an earlier return of continence than the anterior approach. So our randomized controlled trial was specifically powered to see, is this true? Is continence better with the posterior approach than the anterior approach? And the answer is yes. The posterior approach resulted in a quicker return of continence than the anterior approach. Our trial is not powered to look at, is it equally good for cancer control? How do you define cancer control? PSA levels, positive margins? What about sexual function? What about complications? What about lymphocytes? You could have a randomized trial that looked at each one of those variables, but the statistical computation was that it would take several thousands of patients to detect a 1-point to 2-point difference. So randomized controlled trials are good for answering one question well, and they are bad at answering multiple questions at the same time. So of the 4,300 patients that Saurabh analyzed, and I did go over the analysis with him, I had asked him to make a plot, a forest plot, that simply broke it down into minimally invasive surgery better, open surgery better. And the forest plot showed a diamond that crossed 1, which means that no surgical procedure in meta-analysis has minimally invasive surgery been shown to be better than open surgery. So I don't know that we should be that hung up on doing randomized controlled trials. If that is the gold standard, we should not be doing minimally invasive surgery anymore. And I think patients have a strong say in what they believe about that. This is patient-driven. There are other ways in doing these surgical trials, and quality initiative improvement programs are a good way, like the Varicoti Foundation is doing, like Michigan has in a program called Music. I'm not saying that randomized controlled trials are bad. I'm saying that randomized controlled trials are good, they're expensive, they give you the highest quality of evidence, and then ultimately get totally ignored. Thank you.